الرحيم. أول talk Neuroimaging in Covid-19, Dr. Tarek Yousry from United Kingdom.
Good afternoon and thank you very much. So this presentation will be on neuroimaging and COVID, and obviously something that we have been exposed to over the last 20 months or so. So this work is really a work of the European Society of Neuroradiology, and in there the working group, we have created a working group led by Professor Stéphane Crémer from Strasbourg and with members from different centers across Europe. And in the next 20 minutes or so, I'll start with looking at the neurological categories that we have in COVID patients, looking at the MR pattern, the kind of stroke patients can get, and then a brief, a few slides on vaccination and the comparison with COVID. So at the beginning, as you all know, beginning of 2020, I was in Egypt in February, in El Minya, and then Cairo, and then things happened. And very quickly it became clear that it's not only the lung that is affected by COVID, but also that there are neurological manifestations, which you see mentioned here, but also that there is quite substantial imaging findings that can be detected. So very quickly, an association was tried to be found. And if you think from a neurological point of view, it was suggested that there are 5 categories. Encephalopathies, usually not associated with any distinct MR abnormalities. Inflammatory CNS syndromes include encephalitis, ADEM, myelitis, and so on. Also peripheral neurological disorders and ischemic stroke. So I'll start with inflammatory, something brief on the peripheral neurological disorders, and then more extensive on the ischemic stroke. So this is a patient, 60-year-old, presented one day after COVID symptoms and then had confusion and a single seizure. Incomplete recovery. And if you look at the FLAIR images, you see the hyperintensity here in the region of the hippocampus, going back, but also here along the thalamus, along the third ventricle. So this was diagnosed as a limbic encephalitis. Limbic because of the location of the anatomy, and encephalitis as an inflammation. Another patient, 52-year-old, had on day 10, was going to hypoxia, so required intubation, and then was coming off quite slowly from the sedation. And the consciousness was impaired, and you see that there are quite extensive, ill-defined lesions in the white matter, some associated with blood, and in this case, not much of a contrast enhancement. So this was an ADEM with hemorrhage. It's one of the manifestations. This is another patient, similarly. You have a number of hyperintense changes in the T2 weighted images, can show some restricted diffusion, though not necessarily, but also involving the cord. So this was an ADEM with spinal cord involvement. Another patient, aplastic anemia, and after 10 days, consciousness went down, went into speech arrest, and sadly died after 9 days. You see here at the level of the ventricles, of the lateral ventricles, quite extensive changes. In terms of T2 hyperintensity, microhemorrhages, enhancement. And if you go down to the level of the brainstem, you also have here quite extensive changes in the brainstem. Look at these hemorrhagic changes. It's terrible, but also the temporal lobe, and some enhancement also in the brainstem. So this was an acute necrotizing encephalopathy with brainstem involvements. A further patient, 8 days of cough, severe headache, then started weakness and loss of consciousness. had an emergency craniectomy. If you look at the scan, you have a midline shift, which is quite substantial, something that is causing a mass, but there's not much of enhancement here. You have, however, enhancement in other areas of the brain and a little bit of hemorrhagic transformation in this area. And on biopsy was taken because it was unclear at what the diagnosis should be, and it turned out to be a hyperacute ADM. The patient had an incomplete partial recovery. And on this one, patient had a positive throat swab, but a negative CSF for COVID. And if you see here, we have here a hyperintensity of the brachial plexus and also here of the nerve roots, and also some diffuse hyperintensity in the brain. So we have two areas of changes in the peripheral nervous system and in the central nervous system. So this is also where the 5 categories that I mentioned initially of the neurological syndromes come in. Now we all know that disturbance of olfaction is one of the key signs and symptoms of COVID. So what can we see on MR? You see that attention was quickly focused on the bulb and what we can see. And on day 7, when the patient had anosmia, this was how you could image and visualize the bulb. Patient turned normosmia, so didn't have a defect, which was great, day 25. And you see that it is smaller here. So was this a swelling at that time, and did it normalize? It's one of the options. The other things you sometimes can see, you can see a hemorrhage. You can also see a contrast enhancement on the T1 weighted images. But it may not only be focused on the olfactory bulb. You can also have changes in the frontoorbital region, as you see here. Now, we know that some patients recover and get back to normosmia, some don't, and some in between take a long time until they get normosmic again. So, this was a patient who was imaged before COVID, and you see here the volume of the bulb, and after COVID, much smaller. So the question is this an evolution to atrophy, or could it be also, in the first case, swelling? This case suggests that it is more either normal or edema, and then going into atrophy. 2 more cases, one with a normal bulb and one with a hyperintense bulb. However, you have to be careful when you want to look at the bulb, because it has been shown that, especially when using FLAIR, you can get hyperintense signal as an artifact without the patient having any problems with the olfaction. The other point that especially the French group in Strasbourg showed is what they do is giving contrast and then doing a FLAIR sequence. So in this patient, for instance, who was for 3 weeks on the ICU for ARDS, this is the T1 weighted image. You see here the leptomeningeal enhancement, FLAIR before contrast, FLAIR after contrast. FLAIR with contrast is extremely sensitive to showing that. Now, they are doing this regularly, all the time. We don't do it, many people don't do it, but we have to think whether, if we want to see leptomeningeal enhancement, that's the way to do it, namely to do a FLAIR sequence after contrast administration. So it was in their hand, and this is mainly coming from the French group, quite frequent. It can be limited to a certain area of the brain or diffuse. It can be isolated or can be associated with other changes in the brain, probably underdiagnosed because not everyone is using the 3D FLAIR. And it has been described in many other diseases. Also, primary progressive MS, multiple sclerosis. So it is probably a sign of inflammation rather than infection, and it is probably reflecting a lymphocytic infiltration and may not be specific in any kind of way to COVID, but maybe an inflammation going with COVID. So let's move now to the stroke part. And here is a patient where, Now you need to help me. Yes, sir. Yes, sir. It changed to the, maybe this here? No. Ah, I did it. Okay, fine, thank you. So in this patient, you see that you have here a thrombosis of the vertebral artery as it goes up, extending here, and you have extensive hemorrhage of the left cerebellar hemisphere together with some hemorrhagic transformation, and you see it is not only the cerebellum, but it is the PCA that is involved with the thalamus and the occipital lobe. Another patient with ischemic stroke, 57 years, a man, lethargic, and then had a dense right-sided weakness. And you see here a thrombus that developed, and you see the extensive restricted diffusion in the MCA territory, middle cerebellar artery infarct. And you see here the hyperdense vessel, and here the vessel that returns low signal susceptibility artifacting, indicating that the MCA is occluded by its thrombus in addition to hemorrhagic transformations in the basal ganglia. And again, to emphasize the point of thrombus within the vessel, here in the vertebral artery, but can also be in the carotid artery, and it is without calcifications, indicating that it's a new formed thrombus rather than an old one in terms of an atheroma with calcifications. So in this patient, 63-year-old, was intubated in day 6 with a suspected PE, and the pupil was non-reactive, and you see why. It's a massive hemorrhage with a clear midline shift, effacement of the sulci, and obviously a bad outcome. Another patient, not only some hemorrhage within the brain, but also subarachnoid and intraventricular. So all different manifestations. Here you see the poor status of the lung, and then the patient had ECMO, and then afterwards severe pneumonitis, but also multiple hemorrhages within the brain. So you saw this patient before, but it's just when looking at almost 140 patients, of whom almost 80% were critically ill with COVID, and 71% were treated with anticoagulation. It was found, a lobar intracerebral hemorrhage in about 2/3, but also multifocal hemorrhage and a mortality which was quite high of more than 50%. And this is one of our unfortunate post-mortem cases where you have, in this patient, 64-year-old, had COVID-related system, became hypoxic, had to be intubated, or was at that time intubated, ventilated, and then died from multi-organ failure. You see the multiple small lesions with restricted diffusions, and in addition, you also have some areas of microhemorrhages. So on neuropathology, what they saw are these small infarcts, which were also called microinfarcts. Now, you have to be very careful when applying pathological nomenclature to imaging. Quite often you see the term microinfarct being used in the interpretation of MR images. They are not the same. They are talking microinfarct about sub-millimeters. This is not our resolution on MR. So be careful with this language. But what we do see here is microinfarcts on the pathology. And you also see here the multiple microhemorrhages, which were on pathological workup, either acute or early subacutes. So the cerebral microbleeds are actually quite interesting, and you can see them quite extensive on this patient who was intubated and was on ITU. The French team was quite, I wouldn't say aggressive, but quite easy going with performing an MR. In our institution, our anesthesiologists and critical care doctors were not that keen on transporting a patient who was not in the well, who was clinically quite critically ill to transport the patient to our department. But, you know, it gave us a wealth of data. And you see here the changes, especially in the corpus callosum, in the geno, and in the splenium. So is this now a direct consequence of COVID, or is this an epiphenomenon of a severe systemic illness, irrespective of the underlying disease? So in the work that was done in London, they looked at all the microhemorrhages and found a typical pattern, or found a pattern that on the one hand was different from, for instance, cerebral amyloid angiopathy with the other disease with many microhemorrhages. So it didn't have this lobar demonstration, you had it lobar and central. But in terms of the question of severe systemic illness and the epiphenomenon, it is worth noting that it was found that in other patients that there is what was described as susceptibility etching. So patients who were long on ITU seem to be more prone to get these manifestations of multiple microhemorrhages. And if you then look from an infarct point of view, the neurological and neuroimaging findings in patients in 64, over a fourth, over 25% had ischemic strokes, quite a large proportion large vessel infarcts or border zone infarcts, and another important proportion had leptomeningeal enhancement or encephalitis. So to look at this and get a better handle on this, from the ESRNM, as I mentioned at the beginning, a group was formed which looked at centers in Italy, France, Spain, and the UK, and they pooled quite a large number of patients together, almost 500. And then some patterns were looked at. They are mentioned here. You have, for instance, the hippocampus, you have the cortex, there's gray matter, there's a manifestation of gray matter, the thalami, then others in the white matter, that's just, or then the leptomeninges and cranial nerves, or hemorrhages in various areas, single, multiple, microbleeds, or lobar, or subarachnoid, and then infarcts specifically. Was it anterior, posterior, which circulation, small, multiple, border zone or not? And from this data, we found that of these 458 patients, 94% fitted those patterns, and 45% had more than one pattern. So it's not only one of these that you see, but more. But there also were patterns that we hadn't identified, and that includes arteritis, so kind of vasculitis, and posterior reversible encephalopathy syndrome, PRES. Non-ICU patients had more ischemic infarcts than ICU patients, and that was significant. ICU patients had more hemorrhagic lesions, quite more. This is almost 10%, this is almost 40%. Also, microhemorrhages were clearly more on the ITU or ICU than on the non-ICU patients. So this is just one of the patterns that we didn't have, a posterior reversible encephalopathy syndrome in a 54-year-old patient with COVID. So what are the mechanisms of Neuro-Covid? There are three options which have been suggested. One is a direct invasion of the virus to the nervous system. The other is an immune-mediated complication, a post-infectious manifestation of the disease. And the other one will be coming from the pulmonary and systemic disease. Now, here you have hyperinflammation, multi-organ failure, change of coagulation. Here you have vasculitis. But you can get a stroke through this mechanism or through this mechanism. Encephalitis appears in all of them. So you can have the end effect coming from different pathomechanisms, but also some will only be associated to that, such as muscular damage. This is again to underline the possible mechanisms. You can have hypercoagulopathy, you can have alternation of the alteration of the renin-angiotensin system or cardioembolic manifestation. And vasculitis is something, of course, that we can identify if you use the right tools, if you think about it. So MRA is not ideal for this. But if you give contrast, you can see here the vessel wall enhancement. Now, contrast alone is not enough. You have to use the black blood technique, in which you suppress all the signals from the blood, and then you can see very nicely the enhancement of the vessel wall. And that would be then supporting the diagnosis of a vasculitis. So very briefly about the risk of stroke in COVID versus influenza. Is there a difference? Well, there is. In patients with COVID-19, about almost 2,000 patients, 1.6% got an acute ischemic stroke, whereas in influenza, it's only 0.2%. So there is a significant difference. COVID leads much more often to a stroke. The other big problem that has been discussed is cerebral venous thrombosis. It happens. It was not diagnosed at the beginning, of course. When the numbers increased, it was seen, and it can cause venous infection, hemorrhage, or both, and the mortality rate is not insignificant. Now, the discussion about vaccine-induced, COVID-induced, vaccine-induced, you can get the same thing, we know that, through various mechanisms. And if it is vaccine-induced, it is the outcome of it is worse than non-vaccine-induced, in general terms. What about the thrombosis? So you see here a patient with a thrombus, and in the brain, the trick now is to see where it is. It's not the sinus, it is the cortical veins with a venous infarction and the associated hemorrhage. Not only venous thrombosis, but also ischemic stroke can present, as you see here, occlusion of the MCA with an infarction and hemorrhagic transformation. And here some border zone infarctions. So on this almost last slide, what about the risk of stroke or venous thrombosis after COVID-19 vaccination versus only the infection? Does vaccination increase? Are you worse off with your vaccine? And if you look at the colors, this is with COVID and infection, and this is with two different vaccines. This color is much more than the other colors on this side. So the incidence ratio is much higher. There's no doubt that vaccination leads less frequently to infarction or venous thrombosis than does COVID itself. So in brief, 5 major neurological categories that we need to keep in mind. MR patterns exist, we need to know them. ICU patients usually get, in contrast to non-ICU patients, much more often hemorrhages and microhemorrhages. Non-ICU patients, much more frequently ischemia. Think about the leptomeningeal enhancement that we can see, and it's clear and it's important that we as doctors all know that risk of venous thrombosis and ischemic infarcts is higher in COVID than in normal influenza, and higher in patients getting COVID than in patients who are not getting it and have been merely vaccinated. Thank you very much.
Thank you very much, Professor Tarek Yousry, for your interesting presentation. And you come all the way from UK to enrich our conference. We are really proud of you, proud of your work in Great Britain, and we're proud of your work here in Egypt. So thank you very much for that. Thank you. We'll open the panel only for 2 questions, and we leave the rest of the question to the end because we're already late. So if anybody has any questions, we are allowed 2 questions now. We can ask about the flare with contrast, which is interesting. What do you think about doing flare after the gadolinium?
Yes, exactly. So that's what the French are teaching us more or less in Strasbourg. They have imaged hundreds of patients. They always do the flare before and then the contrast afterwards, and I think it's something we need to think about. We haven't applied this ourselves in our institution yet. We need to think about it, but it's something...
looks interesting.
Yes, absolutely.
Looks interesting. Yeah,
absolutely.
Thank you. Any more questions? Okay. Thank you very much. Now we go to the second lecture. It's by Professor Diana Zadrevest, right? She's the